Good morning and good afternoon. My name is Monica Pica, and I'm with Sachs Healthcare, and I will be your technical assistant for today's webinar. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available soon after the session. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. Please make sure you are not behind a firewall to view and participate in this webinar. A firewall may prevent you from viewing this event. I would like to turn the event over to, once we introduce our moderator, Angela Craig. Ms. Craig is the Critical Care Clinical Nurse Specialist for the ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She is also the Sepsis Coordinator for her hospital and is on the Sepsis Coordinator Advisory Committee for Sepsis Alliance. Ms. Craig has lectured extensively at numerous conferences and webinars on sepsis and hemodynamic topics. She has also published on the topics of sepsis and heart failure. So welcome, Angela.
Thank you, Monica, for the kind introduction. The title of our webinar today is Freshen Up Your Knowledge and Focus Your Fluid Resuscitation. And speaking on this very timely topic is a friend and colleague of mine, Barbara Mclean. Barbara is currently the Evidence-Based Practice Clinical Nurse Specialist for the Division of Critical Care at the Grady Health System in Atlanta, Georgia. She is a member of many professional organizations, including the American Association of Critical Care Nurses and the Society of Critical Care Medicine. She is the recipient of the Excellence in Education Award and Circle of Excellence for the Clinical Practice from the AACN. And she has written extensively, 24 chapters and 16 articles, and is a regular reviewer for Critical Care Medicine, Intensive Care Medicine, and New England Journal of Medicine. Barbara was awarded the Most Valuable Player for commitments to reducing sepsis by the Sepsis Committee at GHS, and she is a clinical advisor for the Sepsis Alliance Sepsis Coordinator Network Advisory. Our speaker has disclosed the following. And this activity has been approved for continuing education. Continuing education is for nurses and respiratory therapists. This educational activity is approved for 1 contact hour. A link to obtain CE credits will be available at the conclusion of the webinar. The below is the accreditation statement on your screen, and we would like to thank Baxter for support of this educational activity. And now, at this time, I would like to turn this presentation over to our speaker and my friend, Barbara Mclean.
Thank you so much, Angela. And Angela and I have been together a lot on webinars, and I'm always so grateful to have her as a partner. I'm also very grateful to Baxter for the support of this webinar, so we can have a wonderful virtual talk with each other about how to freshen up our knowledge regarding fluid resuscitation. Thank you also to Sachs Communications, who is actually the organization that has brought this to you and brings you many other webinars, of which Angela and I have been a part. So we're so lucky, and we feel really grateful. And really, what I want to get across in this topic is to really discuss the focus for fluid resuscitation. And those of you who know me, who've listened to me before, know that I'm very concerned with our endpoint of fluid resuscitation, how we determine what we're trying to drive, how we actually can reduce issues associated with fluid overload or fluid underload, and what endpoints we should be using to drive resuscitation to optimize stroke volume. So I would just remind you, I'm in love with stroke volume, so I have a bias to stroke volume, and I'm going to talk a lot about stroke volume because I feel that's one of the most important endpoints of resuscitation. My daughter used to say to me when I'd say, I love the PA catheter, I love an arterial line, she would say, do you want to marry it? Oh, yes, I think I do want to marry it, and stroke volume is my new marriage partner. And so we're going to spend some time together talking about stroke volume and talking about the meaning of it in our clinical practice. Now, I'd like to remind everybody, when we're defining shock, even though most of our guidelines are written based on something that is palatable, that we've been using for a long time, and that would be mean arterial pressure, it's important to remember that shock states are not dependent on the process of mean arterial pressure. It's actually the process of hypoperfusion. So when we define shock, we talk about the inability of your blood flow or your perfusion to meet your metabolic demands. And that generally presents itself in the acute or critical setting as organ dysfunction to organ failure. And it's a disturbance of the metabolic function of the organs and at the cellular levels. It's the common denominator of all forms of shock, whether it's hemorrhagic, hypovolemic, septic, cardiogenic. All forms of shock are about hypoperfusion with different causes. And of course, we certainly know today and now that we can really appreciate a disorder of cellular oxygen utilization is the underscoring mechanism. Sometimes it's because we have low flow, we have cardiogenic shock, we have hypovolemic shock, we have hemorrhagic shock, and sometimes it's because we've lost our vascular tone, we're vasodilated, and we're maldistributing blood. But it's also really important, and in particular in septic shock and in COVID shock, to remind ourselves about the loss of the endothelial barrier. And in relationship to the loss of the endothelial barrier, I'm going to have a very simple explanation of something known as the glycocalyx. And we're going to talk more about that a little later. But the way I want us together to be thinking about the glycocalyx is that this is the barrier that helps us to keep fluid inside our vessels. And the understanding that particularly disorders like sepsis and disorders like COVID are about loss of that endothelial barrier. And the endothelial barrier, the glycocalyx, is also destroyed by over-distending vessels with fluid. Oh my goodness, after all these years of trying to get fluid on board, now we start to talk about when do you stop giving fluid and when is enough enough. So we just remind ourselves that if we understand that the common underscoring mechanism of shock is inadequate tissue perfusion, whether that's a failure of the glycocalyx, whether it's maldistribution, whether it's a low flow state, that it is inadequate tissue perfusion, and that our goal is not necessarily only related to improving mean arterial pressure, but it is about trying to maximize blood flow to the tissue demand for oxygen. And we think about our categories of shock, and we primarily will talk about hemorrhagic, cardiogenic, neurogenic, septic shock, which is at first glance a volume vascular shock, and later is an endothelial shock that ultimately leads to cardiogenic shock. So you move through all kinds of different shocks with sepsis. And we remind ourselves that the word distributive shock is explanatory for sepsis, for neurogenic, for anaphylaxis. But I personally think it's really important to bring septic shock into its own category because septic shock processes through different states. Now, that's going to be really important in terms of how we're making decisions for volume. I'm not saying to you, change that you give your patient that first bolus of volume because you think they have sepsis, but I am going to talk to you about trying to optimize your fluid resuscitation in an appropriate manner. All right, so when we think about this relationship and we talk about this relationship, we're going to remind ourselves that we hold these hemodynamic truths to be self-evident, and that is that tachycardia is never good. It always represents that your patient has a sustained compensatory response. So am I happy and shocked that you have tachycardia? Yes, because it's heralding that you're compensating, but I need to figure out what you're compensating for. Same with sustained tachypnea, one of the most important vital signs in shock states. Sustained tachypnea is a good thing because it represents compensatory response, because a compensatory response is required in relationship to metabolic acidosis. So it's really good, but it's compensatory, and I need to figure out for what is it compensating. It's also really important to remember that hypotension is always pathological if it's abnormal for that patient, not somebody who normally has low pressure, but hypotension as an evolutional sign is always pathological. And it's also a very late sign. So by the time you have hypotension, I should have been paying attention to the tachycardia, the tachypnea, and even more importantly, I would love to know what your stroke volume is. Now, Paul Marino and also Paul Merrick actually say there's no normal cardiac output, which we would generally say, like on a test, normal cardiac output, 4 to 8 liters a minute. But here, I want you to remember that the only normal cardiac output is the one that actually responds to our cells. So I'm not sure what happened. My little slide went forward. I'm sorry, I went back. And just to remind myself that the only normal cardiac output is the one that answers the cellular call for oxygen, and that you have to think about stroke volume. Remember that cardiac output is heart rate times stroke volume. A normal stroke volume is 60 to 100 mLs per beat. But the normal compensation that we will see at the bedside is that the heart rate increases. That is not an efficient form of compensating cardiac output for tissue demand for oxygen. So we always want to focus on stroke volume. And it's also important to remember that CVP is typically not elevated because you gave volume. CVP is typically elevated because we've had loss of right ventricular, right atrial, or valvular compliance. It is typically elevated because of pathology, not because of volume. And also really important to remember that even if I've maximized my cardiac output, maximized my oxygen carrying capacity, it may be that that won't benefit my patient at all, which is why I have to look at how I'm evaluating this optimization at the bedside. So again, we hold these other truths to be self-evident, and that is shock is a state of low tissue perfusion, which is inadequate for your cells to actually function metabolically and from a respiratory perspective, actually utilizing glucose or carbon chain molecules. Shock, by the way, is not synonymous with hypotension. And what that means is that when we wait for hypotension to occur, we've missed opportunities for appropriate resuscitation and ultimately reduction of mortality and morbidity. So let's just all reflect on what it is that we traditionally evaluate and monitor. We talk about blood pressure. We have a high respect for blood pressure, as we should. And then we focus on mean arterial pressure. But new current bodies of evidence are actually discussing that even with a controlled mean arterial pressure above 65, we may not have adequate perfusion. It may even be hypoperfusion. So we're rethinking some of our mean arterial pressure strategies. That's for tomorrow, not for today. Today, you're still looking at mean arterial pressure. You think also our traditional measures, looking at CVP, looking at pulmonary arterial diastolic pressure or pulmonary arterial occlusion pressure, better known as wedge. These are traditional measures, but they are measures that are looking at static environments. Now, static environment doesn't mean that those numbers don't change. That's not what static means. Static means I'm not evaluating them in response to a mechanism that will create some change and tell me how your system responds. So let me explain that really quickly, and we're going to look at it more in depth as we go forward. A static measure means that it's the static environment that exists inside the human body. But if I want to do a dynamic measure, I need to actually intervene. What, in this case, what we're talking about is if I give you a fluid challenge, I need to have endpoints that are going to measure your response to the fluid challenge. So static measures are not in and of themselves non-dynamic. They are measures that change over time, but we're just observing passively how those measures change over time. Dynamic measures change in direct response to an intervention, and that's our focus for today. How do I look at dynamic changes, and are those meaningful in answering one of the most important questions, which is, do you need fluid? When is enough enough? When do I stop? And when do I take fluid away? Important, critical questions that keep us all up at night. So I want to remind you, when we think about our monitoring measures historically, we think about CDP, PAD, mean arterial pressure, and blood pressure. And in the recent years, most of us have evolved to talking about stroke volume and reminding ourselves that we can measure stroke volume in a wide variety of ways. There's many different tools for measurement of stroke volume, wide variety. But every critical patient deserves a measurement methodology for stroke volume, because stroke volume tells us about the efficiency of your ventricle and if your ventricle can actually accept volume and eject it. So why is it that this is so important to us? Why are we so concerned about stroke volume versus blood pressure, either systolic pressure, mean pressure, or diastolic pressure? Because stroke volume gives us a measurement of cardiac response to volume loading, and that's going to be very important. Many of us look at systemic vascular resistance, which is a mathematical calculation. Very nice. If you use it, lovely for you. Systemic vascular resistance is a calculation that primarily depends on your cardiac output. Cardiac output is the denominator. And so with systemic vascular resistance, we're going to go back to what's important in that calculation. That's cardiac output. What's important in cardiac output? Heart rate is the compensatory response. Stroke volume is the efficiency response. Oh my God, I love that so much. And then we think about other kinds of endpoints, and beyond the capability and the time for this talk, but things like looking at the amount of oxygen that remains on hemoglobin after oxygen's been released in the capillaries for the cells to use. That would be SVO2 or SCVO2, and also the adoration of my hemodynamic existence, and that would be base deficit. Base deficit measures the amount of circulating buffers that have been taken out of the circulation because they're bound to metabolic acid. So when your base is in deficit, your acid is in excess. So base deficit, stroke volume, really important criteria that should be part of our toolbox, not the end-all and be-all, but part of our toolbox in hemodynamic resuscitation. And then we think about our clinical measures that we talk about today, okay? Hypotension, alterations in stroke volume, decreasing urine output below the KDIGO guidelines, that would be 0.5 mLs per kg per hour for 6 or more hours, and utilizing urine output as an indicator of hypoperfusion. And of course, metabolic acidosis, and certainly last but not least, is a change in level of consciousness that is associated with reduction of oxygenated blood flow to the brain. A big mouthful of physiologic measures. But now, measures that we should be considering really are dynamic. And you hear people everywhere talking about dynamic measures. Those dynamic measures, so this is not a complete list, everybody, and I don't want anyone to get upset. So dynamic measures are, what happens to stroke volume when I give you volume? Because when I give you volume, I'm giving that into your veins, somewhere in your veins, peripherally, centrally. That means I'm giving it into the right heart, which must communicate it through the pulmonary bed to the left heart. The left heart must accept that volume and eject that volume into the systemic artery. So I'm going to look at stroke volume, and I want to look at that either in the intrathoracic cage. I might use an echocardiogram. I might use POCUS. I might use bioreactance. Or I'm going to look at it in the arterial bed with any of the methodologies that we can use to help us look at stroke volume. But we're using it dynamically, not just, oh, I've got it on the monitor, I write it down every hour, nobody treats it, nobody pays any attention. That's not how we use it. We need to use it as a responder to fluid. Now, for some folks, maybe they don't have that methodology. So we might look at systolic blood pressure as a major indicator and as a dynamic response, but it's very hard to quantify that, which is why most of us don't do it. We also talk about systolic pressure and systolic pressure variation, reminding ourselves that systolic pressure is a reflection of LV ejection into the systemic arterial beds. So I know there's some questions about that. I'll answer them at the end of the talk if I haven't answered them within the talk. So the best really in today's world, today, which is not tomorrow and is not yesterday, it's today. Today, we talk about dynamic measures. The most reliable measure would be stroke volume. And a second measure, which may depend on the type of equipment you use, whether or not your patient's intubated, what your dysrhythmias are, depending on the type of equipment, would be the variability of stroke volume across intrathoracic pressure changes, because that affects what the right heart is communicating to the left heart. But what we want to remember is the day is over. I mean today, the day is over when you just give fluid based on a protocol without an endpoint. And the primary recommendation in today's world is that your endpoint should be a dynamic endpoint, which means I gave you fluid and I saw the response. I gave you fluid and I saw your stroke volume go up. I saw your stroke volume go up at least 10% when I gave you a 500 ml fluid bolus. I saw your stroke volume variation reduce 2% when I gave you a 500 cc volume bolus. I saw your systolic pressure go up 10% when I gave you a volume bolus, but a pure endpoint in terms of resuscitation. Now, for me, I'm going to balance that also. Maybe after I've given you volume, I see your stroke volume goes up. I've given you volume again, I see your stroke volume goes up. I'm going to typically want to balance that with indices of real-time, right now, metabolic acidosis. And for me, that will be your base deficit. So again, we think about our physiologic devices, our measurements, the things that we've thought about. And I would like to remind you that we're going to really focus that discussion at the bedside with our colleagues, with everyone who's coming to the bedside. We're going to focus to these three questions. Is there an evidence of volume load if the stroke volume is adequate? Okay, so if I have a stroke volume adequate, meaning my stroke volume is between 60 and 100, now I'm going to think about, are my neck veins distended? Have I gained weight? Is there interstitial edema? And even at this point, I might actually think about the CVP. But I want to remind you that the most important thing that happens in these critical patients is that the volume load, and when we're resuscitating with volume and we're looking at your volume load, that volume is oftentimes in the wrong compartment. The wrong compartment is intravenous. The wrong compartment is interstitial. So if I have infiltrates or effusions on the chest x-ray that have gotten worse over a period of 3 days, my urine output has gotten worse over a period of 3 days, my patient's body weight has increased over a period of 3 days, and it's obvious to me that the patient has interstitial edema, despite the fact that he's hypotensive, despite the fact that he has poor renal perfusion, I have to say that my patient has interstitial and venous hypervolemia, but I have evidence that he has intra-arterial hypovolemia. And the endpoint to that is whether or not his tissues are perfused. So again, the reactant way of being at the bedside is your blood pressure drops and I give you volume. It may not necessarily affect your blood pressure, and I'm not actually looking at your stroke volume. So let's say if normal stroke volume is 60 to 100, and I have a patient whose stroke volume is 48, and I give them 500 cc's of volume, I'm not really looking at their blood pressure as much as I'm looking at, did that improve stroke volume? So I gave you volume and your stroke volume stayed the same or it got worse, I'm not going forward with any more volume because your ventricle can't handle it. Now I'm going to consider an inotrope. But if I'm not looking at stroke volume as a dynamic responder, I'm not able to make that differentiation. I'm reacting by blood pressure, giving you volume, volume, volume. And I'm not saying that's terrible. I'm just saying it's not specific. So if we have an understanding of what I am saying to you, it's really important for us to understand that stroke volume is responsive. When I have an efficient ventricle, it's responsive to fluid. When my ventricle is inefficient, it's not going to be as responsive to fluid. It might be more responsive to inotrope. And yes, indeed, I do know that inotrope has an E at the end. I'm so sorry for the misspelling. Very sorry. So really important to remember, volume resuscitation must create an increase in stroke volume for me to know that that's actually what you need. So that brings us to the point that we remind ourselves that cardiac output is a balance between heart rate and stroke volume. Heart rate is the compensatory mechanism. Stroke volume is the efficiency response. This is gorgeous. This is what we want. We have a goal to increase stroke volume. The patient comes to you, he may have had venoconstriction, he may have increased his own stroke volume, but he also is compensating by an increase in heart rate, which in and of itself is extending myocardial injury, increasing the demand for oxygen at the myocardium. It's not an efficient way to increase the overall cardiac output. Best efficiency is increased stroke volume, and that's what I want to do. And I'm going to look at stroke volume also in relationship to the way we deliver oxygen to the cell. So our tissues consume oxygen. We deliver oxygen to the cell with the most important component, which is overall cardiac output, by having an efficient stroke volume. I don't know if I can say that any more clearly. Cardiac output is a general number. Stroke volume is the ventricular efficiency. So I need your stroke volume to increase when I'm trying to manifest a better blood flow at the tissue level. Because what I want to see is your cellular metabolic dysfunction, which is what produces lactic acid, which is what produces metabolic acid, and the respiratory dysfunction of the cell, which is what produces CO2. I want that to decrease. So I'm driving towards two things, stroke volume and, as best as I possibly can, the obliteration of metabolic acidosis, whatever I can control, because many times I can't control it. So that kind of brings me to this very simple slide, which if you've heard me speak before, you've probably seen it. It's a slide I developed that I think is one of the most meaningful things that just brings it to alliteration. It's illumination. All shock has low blood flow. Hypovolemic shock, cardiogenic shock, and decompensated sepsis, we assume has a high arterial vascular tone, arterial constriction, because the cardiac output is low and the calculated systemic vascular resistance is high. So hypovolemia, cardiogenic, and decompensated sepsis. Are there other forms of shock? Yes, but just in general, I'm talking about the most common forms. Okay? And then I just remind myself that stroke volume goes down in hypovolemic shock, cardiogenic shock, decompensated sepsis. Stroke volume goes down. One because of volume and the other because of myocardial dysfunction. Volume or myocardial dysfunction. But in compensated sepsis, the stroke volume goes up, which is why typically in early compensated sepsis, we use aggressive volume resuscitation, but in decompensated sepsis, we actually are going to reduce our stroke volume. Okay, so very good. So just to remind ourselves that hypovolemic shock is low volume, low flow. Cardiogenic shock is high volume, high veno volume, and low flow. Compensated sepsis is high arterial volume and high flow, and you have mechanisms occurring at the endothelium that are occlusion to perfusion. Compensated sepsis is high veno volume and low flow. Okay? So we want to remind ourselves that stroke volume is going to give us a lot of information about those types of shock. But all shock have metabolic acidosis. All shock have mild to severe base deficit. And our focus is, can I maximize stroke volume? And that is the critically important piece here. So we just think about our simple components of perfusion therapies. Hypovolemia for fluid resuscitation. If you need fluid, or if I don't know if you need fluid, but I need to test your ventricle, I'm going to give you fluid. And if you're responsive, your stroke volume will increase. If you have loss of vascular tone, I'm probably first going to give fluid, and then I'm going to see that you're not particularly fluid responsive, and I'm going to add in vasopressors judiciously. But the other point here is we'd like to try to not over-distend the vessels by volume overload, which will destabilize the endothelial barriers. So when we've lost vascular tone, aggressive fluid resuscitation is not the end-all and be-all. Once you reach your stroke volume plateau, you're going to move to vasopressors because you don't want to over-distend the endothelium and destroy the glycocalyx. And myocardial efficiency, I'm always going to consider inotropes. Okay, so for today, we're going to think about the evaluation treating of absolute or relative hypovolemia, relative because I have a large vascular bed, and that most particularly is going to relate to sepsis and COVID-19, but also to hypovolemic shock. Okay, so what we want to remember and think about as we discuss that is that the last update in 2018 of Surviving Sepsis campaign, new updates are coming out this pretty soon in the fall, was always consider, just in terms of therapeutic intervention, broad-spectrum antibiotic and a rapid administration of 30 mL of crystalloid for hypotension or lactate levels of greater than 4. Now, I'm not telling you that you're necessarily going to change that initial volume resuscitation, although I'd love for you to be measuring stroke volume. But after initial resuscitation, you must actually consider that if your stroke volume is not responsive to fluid resuscitation, you've got to stop giving fluid because they may not be able to handle it. And maybe they don't need it, or maybe they've already just had enough, which is why we look at stroke volume. And we know from many of our hemodynamic leaders that only 50% of unstable ICU patients are actually fluid responders. Fluid responders are people who get a fluid challenge and have a dynamic response. Remember that key word, dynamic response. So very, 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 very important for us to remind ourselves that as we look at those patients, we think about the evidence of volume overload. And nowhere did that come more clear in COVID-19. That we were looking at two types of patients who had compliant lungs and were responsive to oxygen, and patients with non-compliant lungs who needed higher levels of PEEP. We saw the flowering of the ground glass phenomenon in those patients profoundly exacerbated in volume overload. And we saw that as well in kidney dysfunction. So we also saw that as we were aggressively volume loading COVID-19 patients based on sepsis guidelines, we were actually potentially trying to do the very best we could, of course, but potentially harming patients. And much of that is, again, related to the overstretching of the vessel wall and the injury of the glycocalyx. So remind ourselves what we've been resuscitating to. Blood pressure, CVP, urine output, MAP, SVR, without actually having a method to evaluate the responsiveness to the actual fluid resuscitation. So very important when we're evaluating that. So first problem, traditional preload indicators. Preload indicators do not reflect volume, they reflect pressure. And they reflect pressure as a perspective of compliance of the chamber being filled, whether it's the vena cava, the right atria, the right ventricle, the left atria, the pulmonary vein. It is the compliance of the chamber being filled. It is not linear. It is not a volume measure. It is an indicator. We want it to be volume. It's not. It's pressure. So it doesn't really tell us about volume. The second problem is that we don't understand a fluid challenge versus a fluid load. A fluid load is when your doc writes for you to give a fluid bolus and you hang it on your pump and give it at 999, which is basically just fast trickle flow. Fluid challenge, I'm giving it with a pressure bag. I'm going to give it fast, 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 and I want to see how my patient's going to respond. Want to remind you that typically if you're doing fluid load without responsiveness, without looking at dynamic response to your fluid administration, the problem is that you never know when enough is enough. And this is a beautiful diagram from Manu Malbrain. It was published in 2018, where we just didn't know when enough is enough, and we were causing all sorts of sequelae across all the organs because of over-aggressive fluid resuscitation, because we didn't know when was enough because we were resuscitating solely to blood pressure or to heart rate and blood pressure, or maybe even to heart rate, blood pressure, and base deficit, but not actually evaluating whether or not the ventricles were efficient. And of course, we come back to the endothelium. So this is a whole lecture, a whole day actually, in and of itself. But what I want you to remember is that the glycocalyx is the barrier that opposes vascular permeability and limits the movement of fluid. Now that's degraded in sepsis. It's degraded in COVID. It's degraded in any hyperinflammatory state where you have cytokine mobilization. So because you become holy, what actually happens is if I'm driving up, if this is inside the vessel, so inside the vessel is the white part in the lower right-hand corner with the blue. If I degrade the vessel volume by hydrostatic pressure, which it would not normally move out of the vessel into the interstitium, that's what happens when you lose your glycocalyx. So I love to show this. It's just basically a micron photograph, a micron photograph of the glycocalyx, which looks like something called a brush border, and you can see that all those little hairs are projected in the vascular lumen. They are protecting you from your volume moving from inside the vessel into the interstitial space. And when we talk about damage here, we talk about fibrinolysis, we talk about vascular tone, but most importantly to remember, I may not be able to control the cytokine effect on your glycocalyx, but oh my goodness, better control how much I might be affecting your glycocalyx by giving you fluid. So in today's world, in the recent 2 years, hundreds of publications talking about fluid overload in the ICU, the evaluation, the management, talking about the septic endothelial glycocalyx, talking about the COVID glycocalyx, talking about fluid management, that it might be time to actually, first of all, transition from mean arterial pressure to stroke volume and dynamic response. And also, as you can see here, time to start considering when is enough enough. And that's what we're all struggling to discover. And that's why we have to use methodologies that give us that information. So the reason we give volume, even though you may not think that, the only reason you give volume and the only reason you give a fluid challenge is because you want to increase stroke volume. You think it's because you want to treat MAP, but it's really because you want to increase stroke volume. So reminding ourselves that if the heart is unable to accept the volume that I've administered because it's non-compliant, it's over-distended, there's too much resistance, I'm not able to manifest and accept the volume that's been administered and eject it. That is really, really important. And that is why we give fluid, because we want to improve your stroke volume. So it's, again, really important as we look forward to our future, and some of our future is here today. Now I want to translate that into practice. Okay, and the way I'm going to translate that into practice for today's seminar is I'm going to talk a little bit about the FRESH trial, which is a trial that was just recently published. We're going to have lots of reference to it. The FRESH trial was a fluid responsiveness trial, and utilized more particularly than anywhere else, at least in my institution, was in the emergency department, utilizing bioreactants, or something that's now called the Starling, also known in the past as Cheetah, was a non-invasive cardiac output stroke volume monitoring methodology using bioreactants. And having that methodology, which does not require anything invasive, gave especially our providers in the ED and the ECC a methodology to track and trend their fluid administration. So used in the setting of hypotension or hypoperfusion, looking for a 10% change, a delta change in the stroke volume with either passive leg raise or fluid challenge, that means your patient is accepting the fluid. And if you give a PLR or a fluid challenge and using small aliquots of fluid, in the trial it was 500 ml, less than 10% of delta in the stroke volume or change in the stroke volume, patient's not a fluid responder. Now it's time to move forward to inotropic vasopressor. So the goal of the FRESH trial was to actually evaluate if you had a methodology for looking at stroke volume, and we're basically doing basic resuscitation on your sepsis protocols and then looking at optimization. So again, not necessarily changing your sepsis protocols that you might be doing 30 mLs per kg in initial evaluation, but what are we going to do next and how we're going to evaluate next? Well, I happen to be, I would like to say, I was one of the investigators. I was not a principal investigator, so my name is not on the article, but I worked with Dr. Andre Holder. And what you're seeing here, making that fluid responsiveness more meaningful in that FRESH trial, this is the basic protocol that looked at our patients and helped us to make determinations whether or not we should continue along with fluid. It's small on your screen if you're seeing the slide in a small way, but it's just, this is the basic protocol that we use to determine if patients had persistent hypoperfusion, if they responded to PLR, and then we would give more fluid. So remember that PLR is a test. PLR is a beautiful test that actually tells me if you start in a semi-recumbent position and then I lay you flat and lift your legs to 45 degrees, I give you a short-term fluid bolus. And when I give you that short-term fluid bolus, I see if you respond. As soon as I bring your legs down and set you back up, but even just bringing your legs down, that reverses the fluid that I gave you. So PLR is not a treatment. PLR is a diagnostic tool. Gorgeous, gorgeous, wonderful, fantastic. Except it has to be done in a particular way. So one of the benefits that we had, of course, when we were in the FRESH trial, is that we had trained researchers who would come to the bedside of the patient day or night, patients who met criteria for sepsis, and they would evaluate the patient. They would do a PLR. They would call a person on call, and if it was the daytime, the person on call would come see the patient. But if it was nighttime, and I only had 10 nights of call, but I would make a decision about whether or not, based on the PLR, I wanted to give more fluid. That would be my decision. So after you give a PLR, your patient has already received their initial resuscitation. Now you're doing a PLR to determine responsiveness. And basically I would say, yes, give 500 more. No, don't give more fluid. So very critically and very importantly, it's really vital to be able to turn this into practice. It seems really easy. So first night on call that I was on call for the FRESH trial, I got called as a 48-year-old with suspicion of sepsis, hypotensive tachycardic tachypneic, stroke volume is 84, stroke volume index is 41. Ms. Mclean, what do you want us to do? I'm like on the phone. I'm now so appreciating being an on-call doctor. I have to make decisions about whether or not I want this patient to get fluid. And I felt like I was in the judgment of Cambyses. You can see this guy is getting bled here, and they're opening up his fascia on his left leg. I was like, oh, I'm going to make decisions for this patient. Okay, so with the PLR, what happened when they did the PLR, we had a pretty successful response. His stroke volume responded. His stroke volume index responded. Phew! It was easy for me to make a good decision. Let's give 500 more cc's of LR. And after that happened, 1 hour later, stroke volume was 96, SVI was 52. So just remember, SVI's index to the body surface area typically is around half of your stroke volume. And so they called me again. Miss Mclean, what do you want us to do? When we did the PLR, stroke volume was 95, SVI was 50. Okay, no more fluid. Patient responded. Patient responded to the first bolus. He responded to his first PLR, but he didn't respond to his second PLR in the way we wanted, so we stopped. Beautiful, fabulous. Made it so easy, I felt like I was an angel arising from the phoenix, because honestly, I was worried about making that decision, but the decision became so clear. It was so clear, and it really made it simple for me to make a decision. So take home points from this, and these are the take home points from the FRESH trial. Dynamic fluid responsiveness monitoring tells us when to give appropriate fluid resuscitation. Giving fluid appropriately improves patient outcomes. Ha ha, you say. Really? I want to see that data. And you know what? I'm going to show it to you. So very important to look at this data. When you're looking at the red lines, that's usual care, and the blue lines, the red lines are intervention, and the blue lines are usual care. So when we look at fluid balance at 72 hours after admission into the hospital, what you actually could see that you used much less fluid, but of course with a standard deviation, than usual care. Now that's at 72 hours. So you're past your initial septic event. And what you're seeing here is that these patients have a much higher level of fluid balance, positive fluid balance. The fluid balance is much lower in the intervention. And then you look at length of ICU stay, where it almost looks similar, but once we actually expose some other information, you are going to be so happy. And of course, up here is Ivor Douglas. He is the main author, and that was published in Chest 2020. Just put in FRESH, all capitals, FRESH for fluid, and you can get that article. It's available. You don't have to pay for it. You don't have to be on any special site. All right, now we look at hours on the ventilator, intervention versus usual care. So, of course, you again have some standard deviation, but look at usual care. Many more hours on the ventilator with a much wider standard deviation. Hours with vasopressor, very similar, except much less standard deviation. So in the interventional arm, much less time on vasopressors than the patient in usual care. And then a beautiful one, which tells us, when you were doing your interventional, you may have had more changes in your serum creatinine, although absolute was similar. This is excluding anybody who's on CRT. So this is just looking at, you might have started with 0.04 and now you're 0.08. So you've had some changes in your serum creatinine. And you can see that between both arms, not necessarily a big change in the serum creatinine that first 72 hours, but a wider standard deviation with the intervention because we kept those patients a little bit drier. But now we're going to look at something really beautiful and meaningful. Okay, so if we're looking at intervention versus usual care, you can see across the board, look at that. Need for renal replacement therapy significantly reduced with the intervention group than the usual care group because they were not volume overloaded. Need for vasodilators, vasopressors, length of ICU stay, hours on the ventilator, vasopressor, this is ventilator use, this is vasopressor use. This is, of course, looking at these other issues of the serum creatinine. And remember, in the intervention group, there was more change in the serum creatinine, but it was still very similar. And then looking across the board, length of stay in the hospital, incidence of MACE, M-A-C-E, and looking at these other incidences, you can see that overall, controlling fluid resuscitation actually significantly and improved how our patients did. So in the FRESH trial, what we saw was having a dynamic endpoint actually changed the way we were administering fluid. So that brings us really to the ROSE concept. This is also from Manu Malbrain, and it talks about fluid stewardship. And it just reminds us that the recommendation at today's world is not necessarily for you to change that first hit volume resuscitation in the first few minutes, that you're going to resuscitate your patient first with fluids. But after you do that initial resuscitation, you have to think about optimization. And that's what's happening after those first few minutes, over the next few hours. You need to focus your fluid resuscitation. So my goal would be, ultimately, we're looking at stroke volume from the get-go, but reminding ourselves that for today, what we're going to say is don't go home and change your sepsis protocols this moment. Do your volume resuscitation, but in that interim time while you're resuscitating, find a way to look at stroke volume so that as you move to optimization, you don't just keep giving fluid. You're going to focus fluid on stroke volume and on dynamic responsiveness. That's what I think is important for us to hear today. Find a way. Find a way in any methodology, any well-founded evidence-based methodology. And here you're seeing an evidence-based methodology that was actually focused on utilizing the Starling device with bioreactants, non-invasive, anyone can operate it, and it gives us the answers to our questions. Should I give this patient more fluids? Will he actually respond to fluids? Does that fluid challenge, that fluid bolus, augment stroke volume and tissue perfusion? If not, why does my patient need fluid? If yes, how much? How frequently? And most of that's going to be determined by the marriage of your stroke volume and your base deficit. So monitoring response of patients' hemodynamics related to your therapies and your interventions, that's where we are today. That's where we're going tomorrow. We're going to continue to grow our knowledge base, our evidence base, our research. We're going to move forward, 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 forward. And just remember, we want to focus fluid resuscitation because dynamic response, meaning how did you respond to the fluid, that's the real deal. Focus your fluid resuscitation. Thank you so very much. And I'm going to turn this back over to our wonderful moderator, Angela Craig.
Thank you, Barbara. Wow, what an incredible presentation. You are so awesome. I do want to remind the audience just real quickly how they can obtain their CEs for this activity. Continuing education is for nurses and respiratory therapists. This educational activity is approved for one contact hour. To obtain these CE credits, you are going to go to www.saxtesting.com/RB. You will need to register at the site and complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. An archived/on-demand version will be available on www.right-balance.org. An email will be sent out to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. And with no further delay, Barbara, I've got some questions that people have sent in. So first is from Wesley. Can you talk about why we use MAP instead of systolic blood pressure in sepsis?
I love that question, Wesley, and thank you so much for asking. It's such a great question. So the truth of the matter is we want to remind ourselves that if we really take a look at blood pressure, the diastolic pressure is a reflection of vascular tone, and the systolic pressure is a reflection of the arterial response to ventricular ejection. So they're both relatively complex, but just in our mind, what we're going to say, diastolic pressure is vascular tone plus fluid in the vessel. Systolic pressure is ventricular ejection plus fluid in the vessel. So the reason we use MAP is because in the human body, really, you only have systole. You just have ventricular ejection, right? And ventricular ejection is pushing the column of blood all the way through the arteries, through the capillaries, through the veins, and all the way back to the right heart. And mean arterial pressure gives us a reflection of that relationship. Just like when we talk about mean airway pressure with a ventilator, how do I keep your lungs open with a mean airway pressure? Mean arterial pressure is a better indicator of how I'm keeping the vessels open and mobilizing blood flow from arterial to vein through the capillary throughout the entire cycle of rest and ejection. But I would tell you that systolic blood pressure will give you some information about your ventricular efficiency. So do keep an eye on systolic blood pressure. That's really meaningful. And diastolic pressure gives you some information about loss of vascular tone. So do keep an eye on the diastolic pressure. That's also beneficial. But we look at mean because that's the constant driving pressure outside of the auscultation or the reflective rebounding of the vessel. It's the constant pressure that drives blood flow from artery, and really, let me say it this way, from LV through the whole circuit back to the RA. That mean arterial pressure is what determines that drive. Okay? Hope that answers.
That's awesome. And James asks, how does SVO2 change with shock?
Well, it depends on the kind of shock that you have. What you always hope for when you have shock is that your SVO2 will be low, because SVO2 should be low because if you don't have adequate blood flow, your hemoglobin is going to be releasing oxygen very aggressively. So that means when I look at the returning hemoglobin, it should be desaturated. So in hypovolemic shock, hemorrhagic shock, cardiogenic shock, you're always going to suspect that the SVO2 is low because your problem is that you weren't flowing enough blood. Remember, those types of shocks are low blood flow states. With sepsis, what actually happens is because of alterations in your vascular tone, because of maldistribution of blood flow, you are actually typically going to see with sepsis an SVO2 that is reflexively a little bit higher because the hemoglobin did not get the chance to release oxygen. Now that's usually later, that's in later decompensatory sepsis. So if we reflected back on the work of Manny Rivers, we'll remember that when he was in the emergency department, he saw that patients that came in with sepsis, early sepsis, had low stroke volumes and extraordinarily low SVO2. So, they had high stroke volumes, high stroke volumes and extraordinarily low SVO2. So they had a lot of cardiac compensation, and they also had the second compensatory mechanism, which is to release oxygen from hemoglobin. So they had high flow states and very low SVO2, which meant despite the fact that they already had a high flow state, you had to make it higher. You had to give them hemoglobin to transport more oxygen to protect them from the fact that they were already dipping so significantly into their reserve. So here's the thing that I'm going to tell you, and I'm going to try and make it as simple as I can because this is a big talk and it's complex, right? When you look at SVO2, and SVO2, no matter what it is, that is also correlated to metabolic acidosis, and that metabolic acidosis not necessarily being acute kidney injury or ketosis, so really lactic acidosis and hypoperfusion. But an SVO2, no matter what, with metabolic acidosis is horrible. It's dangerous. It's terrible. If the SVO2 is low, I'm going to give more blood flow. If the SVO2 is high, I'm going to try to reduce my patient's shunt by being cautious with the vasopressor. SVO2 with metabolic acidosis, low, normal, high, is always worrisome. An SVO2 that doesn't have metabolic acidosis gives you time to think about what you want to do next. It's SVO2 with metabolic acidosis that's problematic. And so remember, low flow shock states, SVO2 goes down. Low flow meaning not adequate for the tissue. In sepsis, as it decompensates, your SpO2 will normalize and go up, and that means, and you're in the face of some profound metabolic acidosis, you're not actually flowing blood through the capillaries or releasing oxygen from hemoglobin. So it's not one way, it's complex. I hope that answers some of your questions.
Yes, thank you. And there's time for one more question. What are the clinical endpoints for PLR? Wesley asked that question.
Clinical endpoints for PLR, 10% change in 10% improvement in your stroke volume. That's the main clinical endpoint, 10% increase in your stroke volume, a delta of 10%. And that can be applied, delta of 10% stroke volume, delta of 10% stroke volume variation, delta of 10% in systolic pressure, delta of 10% in pulse pressure. It's a 10% change. The change, though, remember, with stroke volume and systolic pressure is a delta change upwards. In stroke volume variation or pulse pressure variation, it's a 10% change downwards. So you're always looking for a 10% change. All that tells you is, oh, your patient likes the volume, so give some volume. That's what that change is giving you, that information.
Awesome. Well, we could talk all day. You are such a wealth of knowledge. We want to thank you, Barbara, for answering all those questions. And I'm going to turn this back over to Monica now.
Thank you. Thank you both. And thank you for this wonderful event. Thank you. And this does conclude our webinar for today. I would like to remind the audience that there is a survey for you at the conclusion that will pop up immediately, and we would greatly appreciate you sharing your opinions on today's webinar. We thank you again. And on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Baxter, I hope you enjoy the rest of the day. Thank you.
Thank you, everybody. Bye-bye.